My name is Vivian. I'm a second-year med student at UVA, and today I'll be talking about public perception of COVID-19 health information as a function of population demographics. Okay, next slide. All right, so just as a quick introduction, I'm sure we all remember all the news headlines back in 2020 when COVID was first declared a global pandemic, and we probably saw charts like this showing the high deaths per capita all across the United States. And even now in October 2022, there have been over 91 million cases and over 1 million deaths just in the US alone. And so COVID definitely posed a lot of new challenges and was a serious public health crisis, something that we've never seen before. And so this is where understanding of public health, public perspectives is really, really important, because in terms of stopping the spread of misinformation and also increasing adherence to public health guidelines, we really want to be able to know what public attitudes are like so we can implement more targeted policies. And so previous studies on SARS and MERS have actually shown that compliance is influenced by three main factors, which are knowledge, attitudes, and practices. And so for this study, we take a look at some of these CAP factors when it comes to COVID. Okay, next slide. Okay, so just to give a brief overview of our methods, this was a non-experimental cross-sectional study, and we focused on the attitude segment of CAP. So our overall question was, how do attitudes toward public health statements regarding COVID differ among different demographic groups? And we basically wanted to see if people agreed, disagreed, or were indifferent toward the following four statements. Social distancing prevents COVID complications. I have trust in federal guidelines. I have trust in state guidelines, and the virus was made in a lab. So we distributed a survey via social media, and we collected responses for data analysis. And after cleaning up the responses a bit to exclude for things like incomplete responses or international residents, we performed a chi-square analysis to see if there were any statistically significant differences in attitudes among different demographic groups when it came to these four statements. Okay, next slide. So this is just kind of an overview of who we're looking at. Here are some of our population characteristics. As we can see, in terms of race and gender, most of our survey respondents were female and Caucasian. However, we did have a nice distribution in terms of age. We had respondents all across the United States, but mostly concentrated in California and New York. And then we saw a diverse range of household sizes and also a very diverse range of where people obtain their main source of information. So it's definitely interesting to see how people across the US were getting their sources of information from sources ranging from the radio all the way to social media and even friends and family. Next slide. So I'm going to dive into each of the results. Basically, each of these slides, I'll have the data table here kind of for reference with all the numbers, but I will also have this like nicer looking bar chart that's a bit easier to interpret on the bottom. But just to kind of go over the data, the rows show the different demographic factors we are measuring, such as age, location, etc. And then the columns are the number of agrees, indifference, disagrees, and also our chi-square statistics. And so the main takeaway for our first statement, which is social distancing prevents COVID-19 complications, is that location seemed to be the factor that was most associated with differences in attitudes. And specifically, if you take a look at the blue bars below, the proportion of subjects who agreed that social distancing prevents COVID-19 complications was higher in California and New York compared to all other locations surveyed. And this is kind of interesting because recent studies on COVID have shown that compared to rural residents, urban residents are more likely to hold positive attitudes toward the effectiveness of preventive measures and are also more likely to adopt those measures. And the reasons right now are still a bit unclear, but this data seems to go very well with what is currently known in the literature. And so when we're thinking about implementing public health education, you know, this urban-rural difference might be something we want to consider in terms of tailoring our messages and delivering our public health messages, such as the benefits of social distancing to the public. Next slide. So the second statement we looked at is I have trust in federal guidelines. And here it's interesting because one of the big factors that seem to play a role in differences in attitudes is where people obtain their main source of information. So if we look at the bar graphs again on the right, for people who said, yes, I use radio as a main source of information, the levels of agreement that I have trust in federal guidelines is higher than those who don't use radio as a main source of information. And in fact, radio users had the highest amount of trust in federal guidelines among the three information sources at 60.2%, compared to TV users who had 53.9% agreement. And then scholarly article users actually had the least amount of agreement at 38.3%. And so again, this brings up interesting questions in terms of what outlets we want to use to deliver our messages to increase trust in certain guidelines. Perhaps radio and TV is the main source that we want to focus on, while for some reason scholarly articles tend to make people more skeptic in terms of federal guidelines. Next slide. So we also looked at trust in state guidelines. Sometimes people might be more inclined to abide by state guidelines rather than broader federal guidelines. And so we wanted to see if there was a difference. And again, here, the source of information was strongly associated with trust in state guidelines, but this time it was actually the newspaper that seemed to be playing a big role. And in fact, people who said, yes, I use newspaper as a main source of information had higher levels of agreement in this statement compared to people who said, no, I do not use newspaper as a main source of information. And so while radio and TV might be bigger swears in terms of federal guidelines, it seems like newspaper is actually the way to go if you want to increase trust in state guidelines. Next slide. And so for our final question, which was, what are people's attitudes on the statement the virus was made in a lab? It gets a little bit trickier here because there's so many factors in play, including race, television, newspaper, essential worker status, state of residence. And this just really shows kind of the demographic factors, the multifactorial demographics in play when we're looking at attitudes toward certain public health statements. But I do want to kind of point out the differences in attitudes among different racial groups, because I didn't really talk about that before in the other results. But here we can see that for Caucasian participants, there was the highest proportion of participants here who said, no, I do not think the virus was made in a lab. And you can see that in the blue bars, whereas other racial groups tended to have more mixed feelings or were unsure about the origin of the virus. And you can see that in the black bars. And so again, this raises some important questions of why these differences exist. Perhaps there's educational differences or differences in socioeconomic status, or even the fact that maybe people work or live in areas of different levels of COVID caseload, and therefore might have different amounts of trust or different attitudes toward where the virus came from. And so I think these are definitely all directions of future research. And I will actually talk about that a little bit more in the next slide. So next slide. So in conclusion, when it comes to attitudes towards social distancing, state of residence seems to be pretty important. A larger proportion of participants in the urban areas in New York and California tended to agree with this statement. However, when it came to federal and state guidelines, the main source of information was an important factor, with radio, scholarly articles, and TV users being more likely to trust federal guidelines, while newspaper users were more likely to trust state guidelines. And then finally, attitudes toward the origin of the virus depended on many, many factors, with race being one of them. Next slide. And so I just kind of want to leave off with some food for thought. As I described back in the results, there's a lot of directions I think this can take, and a lot of factors that we haven't explored yet. And partially that's because there's limitations to the current surveys that we have. For example, do geographic regions or sociopolitical leanings of those regions impact people's attitudes? And as a result of that, can this survey be a good summary of the United States at large? Furthermore, health literacy, I think, is a big factor. Individuals with lower health literacy might be less inclined to respond to a survey like this, but at the same time, those are also the individuals who are more susceptible to misinformation about COVID. And so how do we account for that? And then also if somebody's already distrustful of COVID, they might be less likely to respond to an academic survey about COVID. And so those responses might be left out, and we don't know what the attitudes for those individuals are. And finally, because this survey was conducted back in 2020 at the peak of the pandemic, I think it provides us a nice slice of attitudes at that time. But as we know, we've been learning more about COVID, and the public health landscape continues to change. And so I'd like to see how attitudes are changing over time, and not just in that single moment back in 2020. But nevertheless, I think attitudes are really important in terms of guiding our future public health initiatives. And by better understanding how different demographic factors come into play, we can create more tailored outlets of education that can best serve a diverse range of populations across the United States. Okay, and next slide. Yeah, and that's it. So I will take any questions. Thank you.
Questions? Check. Yeah, I'm curious if y'all found the trust in federal guidelines were affected by the fact that there were at least 4 different iterations of guidelines, and there was incongruence between CDC guidelines and federal guidelines.
Yeah, I think that that's definitely something that we want to consider. The way that we made this survey, we only looked at federal guidelines and we didn't consider CDC guidelines. As you said, there might be incongruencies. And so that's definitely another segment I think that can be investigated, if that answers your question.
I had a quick question as well. Thank you for the talk.
Yeah.
Curious about your point about the I have trust in federal government looking at radio users versus TV users.
Yeah.
The ages of the people who preferred radio to preferred TV, just for additional texture.
I don't have the exact statistics on that. We didn't go that far as to doing within each type of information source what the age breakdown of that was. And that's a really good point, actually, because I'm wondering if there's like some kind of correlation where older individuals might be more likely to use things like radio and TV, whereas maybe younger individuals might use things like social media more. So that's actually a really good point. I don't think we looked into that. And so I don't have any numbers on that.
Thank you very much.
Yeah, no problem.
So in that same deal, did you look at educational level by choice of news information to digest?
Sorry, can you repeat the question?
Did you look at educational level by choice of news information, which one digests? So is there an educational difference between people who choose radio versus choose newspapers versus choose social media?
Yeah, so we did look at educational level in terms of different levels of trust, but we didn't look at if there's a correlation between educational level and the type of, and the main source of information people used. So for each of our factors, they were very like, they were just, is there a difference between this factor and trust in guidelines? We didn't look for correlations among each of the factors.
And another thing, if you're doing future studies on it, that I think it'd be interesting, when you broke it down to identified ethnicity and agreement with statements, it would be very interesting to me to see a question where you placed value on people's views in certain directions. Like if you said, I think it's racist to say that it's made in a lab. Had them create a statement like that to find out if possibly there could even be a level of attempted sensitivity that makes people more likely to answer one way than another.
Mm-hmm. Yeah, of course. And I definitely think there's a lot of future directions this can take. I think there's a lot of kind of these correlations that we didn't really explore. And this is kind of like a preliminary, like these are some demographic factors involved. But like, as you said, yeah, that's definitely a very good future direction to go in.
One more.
I'm a bit curious that the response rate that you got that really made this very much a California, New York kind of centric response.
Mm-hmm.
Was there something about the data, the survey itself or the way it was distributed that would kind of explain that?
Yeah, and I think that's also a limitation of the study is that we distributed this survey via social media groups, so mainly Facebook and also to community leaders. And these groups were mostly in the New York metropolitan area and the San Francisco Bay Area. So just when we distributed it, those were kind of the main Facebook groups and social media locations that we used.
Okay, thank you very much.
Thank you.